and happy to answer any questions.
Anything from the Department of Finance? LAO? No. Okay, Dr. Pan?
So just to clarify, you mentioned that because what I see here is for CCS, we see essentially a 44% reduction, even though the caseload's reported to actually go up slightly. So, general fund revised 96 million down to 78. Federal funds go down to 0. So is that all drug expenses, or can you explain why the 44% decrease in CCS expenditure?
It really is mostly attributed to the rebates. We've also seen a large number of children who were on CCS state only, which is what's currently scored in the family estimate, go to CCS Medi-Cal because of a reduction in income. The families have transitioned over to Medi-Cal and out of the CCS state only. So it's going to be a combination of both of those things.
Okay, so, all right. Yeah, because I can't imagine, unfortunately, those conditions we don't have cures for, so I would expect the numbers of kids who need the program wouldn't have changed that dramatically. So basically, they're shifting from state only to Medi-Cal, unfortunately, probably because their families are suffering economic distress as well as the budget. Okay, thank you for that explanation.
Of course.
Okay, now I think we'll move on to the moment we've all been waiting for, CalAIM.
All right. So, DHCS started the CalAIM journey back in 2019. I actually had the privilege myself to go across the state of California and have conversations with providers, counties, managed care plans, and say, what's working in Medi-Cal and what's not working in Medi-Cal. And the department rolled that out in the fall of 2019, and it was called, California Advancing and Innovating Medi-Cal. And it is a very comprehensive a strategy that then in quickly the public health emergency hit and we put it on delayed and then put it back in the budget that's before you today for consideration. So, what really is CalAIM? I think, for us, we really see it as using a population health management foundation that focuses on improving health outcomes for defined groups of individuals through improved care coordination, patient and community engagement, and appropriate financing and care models. Healthcare has three main levers: benefits, eligibility, and financing, and CalAIM really influences all three of those to change Medi-Cal in a way that we think is going to help provide better quality outcomes for beneficiaries, as well as eventually bend that cost curve. We think that CalAIM helps influence and build the continuum from birth all the way to end of life based on the components in there, and I will go through some of those to kind of highlight how that really helps standardize that. We also you'll see in CalAIM that we are really focused on standardizing across the state of California. It's one of the guiding principles behind what we're doing in there, because we really do think that where you live should not dictate the care that you get. And so one of the fundamental pieces is standardizing managed care enrollment across the state of California, as well as what benefits are carved into managed care versus out. As well as just having a consistent system. You'll also see a focus on integrating across the delivery systems and elevating systems like behavioral health. There's a comprehensive, essentially a fundamental shift in regards to what we are expecting from our behavioral health system. We're proposing things like payment reform, changes to access with medical necessity clarifications, integration, and really expanding access. So we really feel like the proposals are the building blocks for elevating both mental health and substance use in California in a way that we haven't historically done in moving forward. You'll also see in CalAIM pushing a variety of value-based payment initiatives. It focuses on healthcare affordability, as well as making the right investments to bend that cost curve. So you'll see things in CalAIM that include the behavioral health payment reform I mentioned before, where we're currently paying our counties on a cost-based reimbursement, moving them to a fee schedule that allows them to keep funds in addition to over costs that they can reinvest into the delivery system is really important. We talk about shared savings with our managed care plans, incentives and regional rates, really driving at accountability and cost effectiveness within our delivery system is really important. However, I think that probably the largest thing that you see within the CalAIM proposal for at least for the upcoming future, is really learning lessons from our Health Homes initiative and pilot that's been going on in various counties across California, as well as our whole person care. One of the backbones of CalAIM is making sure that we are providing whole person care approaches, addressing social determinants of health and reducing health disparities that we clearly see across the state of California. I think, though, we have had pilots in California for quite some time. We want to take the successes of those pilots and move them to a statewide program. We think that it is really important. Those pilots have been funded, Health Homes, for example, through foundation funding historically, and in the budget had to move to some proposed state general fund there, and then whole person care funded by local counties and public hospital systems. And so in order to have a sustainable infrastructure moving forward, the budget does propose to take the lessons of those in what we call enhanced care management and in lieu of services and take that statewide. We would say that it is important that we transition these things. We've had great lessons learned from Health Homes and whole person care, but they're currently funded in our 1115 waiver, which the state will be transitioning out of. And there is a jeopardy if those programs were to end and we didn't transition to enhanced care management in lieu of, for example, that there would be a funding cliff for our key county and public hospital partners, which is critical for us to sustain. And we really have seen the value of what those bring, making sure we're providing robust care coordination for some of the most vulnerable beneficiaries across the state of California. And so by leveraging it through CalAIM, we really think that we can do that. So now I'm gonna provide some additional information around enhanced care management in lieu of services to provide context, and I'll give a few examples of how CalAIM will help certain vulnerable populations. So one of the biggest things that we learned, and something I, prior to coming to the state, working in a public hospital system and running care management programs, they're so critical to being able to work with very complex individuals who are oftentimes facing multiple chronic diseases, behavioral health concerns, as well as many social drivers impacting their ability to engage in the healthcare delivery system. So we are proposing enhanced care management, which would be a community-based intensive care management program that managed care plans would contract with providers to provide. It would include services for various target populations, including children with complex medical and behavioral health conditions, individuals experiencing homelessness or at risk of becoming homeless, high utilizers of emergency room services, hospital admissions, skilled nursing facilities, just high utilizers within our system, those at risk of institutionalization, as well as individuals who are transitioning out from incarceration. And the idea is to wrap an intensive service around them that is on the ground, go to where that individual is, and provide those intensive services. We're also proposing a list of 14 what we call in lieu of services, and we know it's not a good name, but essentially it's supplemental wrap services that allow us to take some of those social drivers impeding someone's ability to have a healthy life or improve their health, and ultimately reduce the cost of care in what we provide. And there's a long list that includes things like housing navigation, deposits and tenancy support services, recuperative care, respite care for individuals, as well as paying for transitions from skilled nursing facilities to homes or assisted living environments, medically tailored meals, sobering centers, asthma remediation. There's a variety of those services. And the idea is to wrap both the enhanced care management and these additional supplemental services around a beneficiary to allow them to engage in the healthcare environment and lead healthier, happier lives. So I'm going to go through 3 different groups just to give some context in regards to what's in CalAIM, because it's big and complex, and we know that, but the value that it could have on beneficiaries. So let's start with justice involved individuals.
May I ask you just real briefly, like,
Sure.
so on the ground, right? So, because we're going to try to do this statewide, but how about the provider network in these areas? And then when we come to the enhanced case management and care, will everybody get that, or just these targeted populations that we're talking about? And then will they be responsible for providing the health care as well, or just the in lieu of services or the enhanced services, if you will?
Great question. So for enhanced care management providers, really, it's going to depend on who the provider is based on the target population. So enhanced care management is not available to everyone. We have 3 tiers of care management within Medi-Cal. So we have case management, which is available to all individuals in the program based on their needs and is very regularly provided. We have what's called complex case management currently within our contracts, and that's for individuals who have more complex cases, need additional care coordination services. And then what we're adding on top of that is the top level of service, which is enhanced care management. And that is your top highest, most complex individuals where you need a contract with people who really have the ability to move the needle. For example, if you are talking about the homeless target population with enhanced care management, that wouldn't be just a normal primary care provider who would most likely be the enhanced care management. That would be most likely a community-based organization or a street-based team where they're going out on the street, engaging with the homeless population, building that trusting relationship, and ensuring that all of their medical, behavioral health, et cetera, social services are being coordinated. One of the fundamental principles of enhanced care management is that there's one primary care manager responsible for coordinating across our delivery system. Medi-Cal is really complex. We have essentially 6 to 7 separate delivery systems. As soon as you get a Medi-Cal card, you're getting your medical benefits from a managed care plan. You're getting, if you need specialty mental health or SUD, from the counties. If you need IHSS services, we're getting that separate. And so it can be very challenging to navigate that. The idea behind this is for someone who has high complex needs across multiple delivery systems, making sure that there's one person coordinating across those delivery systems, which in this case could include coordinating these in lieu of services, but really trying to tackle that most complex. So when you say the providers, it could be counties, it could be public hospital systems who are doing this today on whole person care, community-based organizations, housing entities, depending on the role that they play. But anyone who contracts with a managed care plan to provide enhanced care management has to be committed to providing it in the community, meeting the person where they are, which can include in a clinical office, but it's really a higher level touch coordination service, if that helps kind of answer your question.
It does. Thank you.
Of course. Sometimes I think it's easy to kind of use populations to kind of tee up how this would work in Medi-Cal. So we'll take the justice involved as an example. In our CalAIM proposal, we allow for a request to the federal government for a 30-day in-reach while somebody is currently incarcerated under the Support Act is what we will be using in our request to allow that enhanced care management entity to go in and assess the individual and ensure that the transition upon reentry into the community is as successful as possible. There's a lot of data that demonstrates that somebody upon being released, especially if incarcerated for a significant period of time and having any complex medical or behavioral health conditions, will most likely result in an emergency room visit or an inpatient stay shortly after being released from jail. So this would allow for that reentry work to start We also have in our proposal a mandatory requirement that all jails and prisons will screen someone for Medi-Cal enrollment upon release, which would allow them to leave, for example, with prescriptions upon release from jail. And then they would have a variety of in lieu of services at their disposal to use if necessary, and if that individual needs those services. So a very comprehensive way where we have essentially said that there are different touch points, and within CalAIM, we're proposing how to do that reentry. It also includes diversion, where we can work on diversion activities within our behavioral health space, as well as with the enhanced care management. The next population would be our homeless population. The various components between having the street-based enhanced care management team on the ground working with individuals. There are a handful of in lieu of services that help with our homeless individuals, including having hubs within large urban areas on the ground that can help target individuals for services, provide services for them while they're still homeless, but then hopefully connecting them into housing navigation. It pays for deposits. And then once they are housed, tenancy supportive services to ensure that they stay housed. And those are really critical components that we've learned from both health homes and our whole person care pilots. And then the last one that I'll give you as a population, and these are just a few, there are many that served by CalAIM, is our aging population. CalAIM provides for one of our target populations is individuals at risk of being institutionalized or put into a long-term care environment. And it allows us to provide both the enhanced care management, but as well as these wrap services needed to keep someone either out of an institution or someone who is in an institution, if they so choose, allow them to transition to their home or an assisted living environment where we would pay the wrap services within an RCFE or an ARF. We would pay for home modifications if that was needed for them to be home safely, as well as medically tailored meals. So it really allows people to safely reside in their home, and it has proven cost savings and improved health outcomes. I frame it in those populations because I think sometimes CalAIM is big and complex, and it's hard to kind of see the direct impact on various vulnerable populations. I think that we have learned a lot from COVID in regards to how critical having some of these pieces in place could help be able to really move the needle in such a real way across the state of California. If anything, it alone has helped underscore the value of the proposals in CalAIM. I think what we would also say is we are not shy to think that this is not a large lift. It is a heavy lift. And in order to ensure success, we have put in the proposal incentive payments. And really the incentive payments are because when you take a pilot and you take it statewide, you need to make sure that people have the technical assistance that they need. And we have parts of the state where we don't have some of these pilots today, and we need to build that infrastructure capacity and access in parts of the states where we clearly just don't have it today. So the incentive payments are there to do that, really to incentivize where we don't have any access to these types of in lieu of services, or we have low access, increasing, or even in urban areas where we had great access during the pilot, but not enough for the demand in that area, building that infrastructure statewide. And ultimately, the goal would be that if we can build statewide infrastructure, we can prove cost effectiveness in regards to what we're doing. Ultimately, even transitioning some of those in lieu of services into a benefit, which currently the way it's proposed, it is not a benefit. It is something that plans would have to opt into providing, and that's how we get the federal authority. And that's really to build that infrastructure across the state of California so we can get to a point where you can demonstrate to the federal government that you have statewideness. And the other thing I would mention quickly is with the building of the in lieu of services enhanced care management, it allows us to get to manage long-term services and supports for our dual populations by 2027, because many of the things offered in CalAIM in the in lieu of services enhanced care management really aim at having someone be able to successfully live in their home and providing those long-term services and supports that they need for us to be able to achieve that in future waivers and improving those health outcomes. In order to do this work, the department is requesting 69 permanent positions and 46 limited term equivalent positions at the cost of 24 million total funds or 11 million general fund. And I think, we know this work is complex and there are so many factors that are interdependent, but I think we really feel like the package as a whole helps really will better serve people in our program to live kind of longer, healthier, happier lives. And I'm happy to answer any questions that you may have in regards to CalAIM.
I think we'll have quite a few questions, but just off the, when you talked about seniors, and PACE is not part of, going to be the part of the CalAIM, or will the PACE program still be a part of that? Because at what point would people transition between those two systems?
So we would, PACE is a different, it's under different regulations. So they're different than our managed care plans. However, we would ensure that beneficiaries understand their right to enroll in a PACE organization, a very effective model for individuals. And we would just make sure that individuals still know they have a right to the PACE plans.
Okay. Maybe we should hear from the Department of Finance and LAO before we get more into questions. Department of Finance?
Nothing to add at this time. Thank you.
LAO?
Hi, thank you, Madam Chair. Ben Johnson again with the Legislative Analyst Office. As is really well summarized in the hearing agenda, CalAIM is a sprawling set of reforms to expand, transform, and streamline Medi-Cal service delivery and financing. It contains at least 18 major reforms that touch on nearly every aspect of the Medi-Cal program. And so far, our office has released 2 analyses that are part of a series of publications that will analyze CalAIM. These 2 existing publications focus on overarching issues as well as financing issues related to CalAIM. And 2 upcoming publications will explore CalAIM issues related to health equity and aging. One facet sort of like to re-emphasize or reiterate, but I think Director Cooper did a great job of touching on, is that while much of CalAIM is new, much of CalAIM would also build upon or replace existing and expiring programs, including enhanced care management in lieu of services and the related incentive payments that would go to managed care plans. But CalAIM does not reflect a mere continuation of these programs. It represents a significant change in the state's approach to delivering and financing the services that CalAIM would aim to replace. First, under CalAIM, significant funding and responsibilities would be concentrated and shifted over to Medi-Cal managed care plans. Second, the state general fund would support major new CalAIM services to a much greater degree than under existing programs, for example, where the local funds provide a good deal of support. We generally find this shift towards the general fund reasonable given CalAIM's proposed design of going statewide and shifting control really in some ways away from the locals and towards managed care plans. And then third, though, CalAIM would significantly change sort of which federal funding sources or authorities the state would use to fund expanded benefits. And this would unlock additional federal funding for non-medical benefits that haven't sort of been funded sort of through the Medicaid sort of entitlement funding structure previously. And it would at the same time make federal funding more sustainable given changes to how the federal government is overseeing 1115 waivers. We find that CalAIM has potential to bring major policy benefits, for example, reducing health disparities by focusing resources and attention on Medi-Cal's highest risk and highest need beneficiaries. But we do have many outstanding questions. For significant detail on major CalAIM components is lacking, limiting the legislature's ability to fully scrutinize all the changes that are proposed. Second, while we find the governor's $532 million general fund funding plan to generally be reasonable in 2021-22, we find that CalAIM, given its scope and complexity, comes with significant fiscal risks over the long term. Unforeseen implementation costs could materialize over the next several years, and anticipated savings may not materialize quickly enough or at sufficient levels for the multi-year funding plan to prove reasonable. These long-term fiscal risks merit especially close attention given the state budget problem anticipated to arise after 2021-22. Third, and despite these fiscal risks, we do believe CalAIM merits consideration given its potential policy benefits and the fact that new but existing services such as those provided under whole person care and health homes would expire absent their continuation in some form, such as is proposed under CalAIM. Just close with a few issues for consideration. First, we recommend the legislature use the budget and policy process to resolve key outstanding questions, learn more about the details of the program or the proposal, and provide legislative input into any CalAIM components that are ultimately adopted. Second, given the scope of CalAIM and the implementation challenges the state is likely to face as we hopefully exit a pandemic over the coming months and years, we recommend the legislature explore where delays in statutory authorization and implementation are advisable. And then third, to ensure CalAIM is achieving the state's goals, we recommend establishing robust mechanisms for implementation oversight as well as program evaluation. That concludes my prepared remarks, but happy to take any questions on our assessments.
Okay. Director Cooper, do you want to respond to any of those before we get into questions?
No, not necessarily. I mean, I think what I would say is that CalAIM, with the benefits put forward, are really meant to bend the cost curve and to be in the out years reducing overall healthcare spending, especially around individuals where we spend a lot of money with long-term care, for example, and transitioning individuals to be in their home safely. We have proven through multiple home and community-based waivers the cost effectiveness of those types of transitions, as well as improved outcomes, and then focusing on high utilizers and individuals with high behavioral health needs has really demonstrated that those things are cost effective. So I understand that this is new general fund cost, but overall, really CalAIM helps really bend the cost curve in the out years. That is the intent behind many of the proposals. But happy to answer any questions that you all have.
Can you talk a little bit more about the CalAIM framework in counties with the managed care aren't included, and how then do we group in the fee for services, or is the plan eventually to get them all into managed care plans?
So one of the proposals of CalAIM is to actually transition a handful of individuals who are currently in our fee-for-service environment into mandatory managed care. So for all non-dual populations, we proposed January 1, 2022 to move into managed care. That includes certain zip codes, for example, across California that are still not in managed care. And then we proposed the dual population move to mandatory managed care by 2023. So the CalAIM proposal does account for majority of individuals moving to managed care. The exceptions of lives that would stay within the fee-for-service environment is restricted scope, as well as share of cost individuals, with the exception of long-term care share of cost, as they often meet their share of cost on day one and would be in managed care. So CalAIM does anticipate that both enhanced care management and in lieu of services are currently benefits only proposed within managed care. But since we are proposing to move the majority of Medi-Cal lives in 22 and 23 into managed care, we do think that that is appropriate.
And do you see any of these services as discrete if as Mr. Johnson said, if things drop or if we're not meeting the numbers, if we have to pare back at some point, do we see services as discrete, or do we see geographic areas as what would fall off? Or what do you think would fall off if we had to pare back?
I think that I would just say that once we make enhanced care management a benefit, it is there are federal regulations in regards to removing benefits for individuals, ensuring that it wouldn't, reduce or hurt outcomes, as well as making sure that they still have appropriate access to services. However, I would say that, with our current public hospital systems and counties that are providing this under the existing 1115 waiver, I really would strongly encourage you to continue the enhanced care management in lieu of services, as there would be a dramatic funding cliff for those counties in public hospital systems if there was not an avenue to move forward with enhanced care management in lieu of services, which would still impact the state budget, including general fund, in regards to ways that we would have to address that hole. And so we strongly think that those items should move forward, and we should take them statewide to ensure that there is a sustainable way of providing those services across the state of California. And the nice thing about in lieu of services being optional is it allows us to phase in over time. It allows us to learn where we're finding successes, and then where we are and where we see that they are clearly demonstrating improved outcomes for beneficiaries, can make decisions, of course, with the legislature in regards to making those benefits. So I think we've tried to phase in, we've tried to account for those types of transitions while not creating unnecessary cliffs for key partners in our Medi-Cal delivery system, to do this as appropriately as we can while we take it statewide.
And can you talk a little bit more about the incentive payments for Medi-Cal? Because that is then the incentive is to go to the enhanced case management, correct?
Yeah, so the incentive dollars are really to build infrastructure in the state for both the enhanced care management, where it doesn't exist today, as well as the in lieu of services. For example, one of the pieces that we are looking to do with the incentives is saying, if you can increase the number of recuperative care beds available in your county, you would be able to receive an incentive payment. Recuperative care beds, for example, are really critical because individuals who are homeless, who go into inpatient care, often can linger in an inpatient bed for weeks and sometimes months because they cannot appropriately transition somebody to the street given their current health condition. It allows someone to transition from that inpatient stay into a recuperative care bed. So the incentives would be around building that infrastructure and capacity across the state of California, which is really critical. It also would focus on certain outcomes, so increasing access to these services to ensure that we're getting the penetration that we want. It could include things like training initiatives for enhanced care management. In order to do enhanced care management, it's a combination of both clinical and non-clinical, where we work with community health workers and peers. And it's really critical that they have training mechanisms. So we could incentivize these training initiatives across the state of California to move the needle in regards to that workforce effort that would be needed, as well as actual quality outcomes. So we'll have measures, for example, and we have talked about things where we want to close gaps. For example, we know that there's a higher proportion of Black and African American homeless individuals compared to the number in the state. And so, reducing the number of individuals or increasing the number of Black and African American individuals who are receiving enhanced care management and in lieu of services to make sure that we are closing equity gaps. Those are the types of things that we are exploring with the incentive dollars proposed in CalAIM.
Okay. Can you, so tell me a story, okay? So let's say we have a high needs individual right now on our traditional managed care Medi-Cal, okay? Mm-hmm. And then describe to me what it's going to look like under the new system. Like that one individual, right? They come in, what are their issues they're facing, and then where do they fall off or where do they not get served, and how is that payment delivered? And then conversely, the beautiful future that we're heading towards.
Sure. So so let's use the high utilizer.
Okay.
So you have a high utilizer, individual who's coming into the emergency room on a very regular basis. And we do have individuals who can have multiple emergency room visits in a month. Maybe they've had an inpatient stay or two, but they keep cycling through the system. Clearly, they are not being connected to the actual delivery system to have whatever medical condition is usually being driven by a number of medical conditions or behavioral health conditions for them. And that is very costly, both to the state of California as well as the managed care plan. And if not identified early, really can have an issue. In CalAIM, what we propose is that we have a clear risk stratification process in place where high utilizers, for example, would be identified through the managed care plan, and that there would be a handoff The referral can come from a provider, from the managed care plan, or the beneficiary themselves, or a family member who says this individual needs care, to an enhanced care manager. Oftentimes, hospital systems are going to be really key players in regards to the high utilizer enhanced care management provider. In this case, they would engage with that individual. For example, some of our public hospital systems have someone embedded in the emergency room so that if you have a high utilizer, you can connect with them, you can build trust, and then you can start ensuring that they're getting the services they need on the outpatient perspective and not in the emergency room if it's not an actual emergency. So they would help coordinate and ensure, if they have maybe they're a diabetic and they have uncontrolled diabetes, they'd be working with them on a regular basis to get in to see their primary care provider, get them any specialty or ancillary services that they need. And maybe that they're also struggling with anxiety, depression, or something on the behavioral health space, ensuring that they're getting coordinated with those services. If the individual happens to also be homeless and an emergency room individual, that enhanced care manager would be responsible for engaging them to see if they want to explore being housed. That process takes time, it takes trust. And so having a dedicated individual that could help with that housing navigation services, connecting them to the in lieu of service provider, working to get that deposit and get them in their house. And once they're housed, working with them to stay housed by linking them with that tenancy supportive services that's offered in CalAIM. That's kind of the difference, where today in certain parts of the state, you just have churn, and managed care plans may call the individual and say, hey, we know that you're using the emergency room a lot. We want to make sure that your services are being provided. That's not always effective as what is on the ground in the either the emergency room, in the provider office, or if homeless on the street, engaging with someone to build a trusting relationship that allows you to kind of move the needle. I've had the pleasure of running enhanced care management programs in my career. It's hard to engage certain populations, so there's always going to be those who just don't engage. But if you can see that engagement, and if you can involve somebody in their care, connect them to the outpatient services, get them into the behavioral health services they need, or connect them with housing or other services. We have shown across the state through both pilots and other initiatives, you really can reduce the high cost emergency room inpatient stays, and you can really improve health outcomes.
I taught practice for years. I taught practice, I taught theory, and I would tell students all the time, you can do any kind of fancy thing you want, but if you can't build a relationship, nothing else really matters. Can you tell me the funding streams for that first, right? So how is a managed care being funded and then paying providers in the traditional form that we're using now, and how is that going to look different in the new form for funding purposes?
Sure. So today, the way we pay for case management, we pay managed care plans within their capitation rate for both case management, complex case management, and then they contract with a variety of providers to provide services, some of which may be providing the care coordination on their behalf, and that's built in. What we're proposing to do in CalAIM for enhanced care management, they would receive additional funds for enhanced care management that would go to the managed care plan, but we are going to have clear contractual requirements that they contract out. So some managed care plans today do the case management and complex case management themselves, where they have nurses or clinical staff who are calling and doing outreach to individuals. Under enhanced care management, we may allow for some portions to stay within the managed care plan, but really this is about community-based individuals or providers, counties, public health departments, or public health hospitals engaging in that care. So they would contract with that entity. They would most likely pay them a PMPM. That's typically what we've seen in most of our whole person care pilots. And that would be to engage with that individual on a very regular basis. And pay them to do so. So it's separate and apart from the services that would be billed. It would be a direct payment to that enhanced care management provider. And that's built into the amount of money that we've put in the budget for enhanced care management. For in lieu of services, since we already have a pretty big infrastructure of in lieu of services built up through whole person care, we have put funds into the budget to ensure there's no cliff We don't want that to fall off. We want them to be able to continue to fund those. But then over time, as managed care plans provide more in lieu of services, that is the hope, especially where there's not some today. After that gets built into their rate process, so we will receive encounter data, we will receive rate data from the managed care plan of what that's costing, and that gets built into their future rate. Also, which gets built into their rate is, if they're seeing that it's reducing the inpatient and ER utilization, we have within our CalAIM proposal a shared savings proposal that as we start seeing those inpatient and ER utilization decreases, that in the out years we would share in those savings with the managed care plans. So say they had a reduction where we were paying, I'm just going to use easy numbers, $100, for something, and they were able to reduce that cost to 80. We would share in that 20% instead of reaping all of that, so that they could reinvest in expansion of appropriate delivery system transformation as well as additional in lieu of services. And so we have kind of proposed both a requirement that the managed care plan contract directly with providers, keeping some infrastructure at the plan level, but most of it being community-based, in person, to build those relationships. And then we will build in the in lieu of services cost over time into the rate and share in the savings of the reduced utilization.
Now, the whole person plans have been in place, the pilots, for about 5 years, approximately?
Yeah, we're in the 6th year technically, but it took time to get them up and running. So I think we're in year 4 of operationally paying for the services. Yeah.
Okay, so I know my county and Sacramento County are both part of it, and now, and I would just offer, in the last 5 years, I think people would say that the problems have increased, as far as the visual problems that people are seeing, that we continue to hear about: homeless on the street, a lack of housing, all of those things. So if in the 2 counties that I drive in every day, I'm not seeing anything. Tell me how continuing on this is going to help even more, or what we've been missing in the whole person plans before.
So I think one of the differences is with whole person care, it's a pilot. So each county was able to pick different target populations and pick different initiatives. And what we've tried to do with CalAIM is look across the programs of what were the best practices, what were the best package of services bundled together that really allowed us to move the needle. And that's what we ended up putting into CalAIM. I think it's one of the things with pilots is everybody's testing slightly different approaches and a combination of things. And so by having the full package of in lieu of services, the navigation, the deposits, the tenancy, as well as recuperative care, and other pieces, you have to have the full continuum. And so what we're really hoping is that people will embrace that continuum of services that allows you to have the step down and really maximize the savings. And I also think that a lot of the stuff in whole person care, it's one of the things that makes it vulnerable, is it is dependent on local funding. And really to drive to sustainability, to drive to statewide-ness, going through the managed care plans where there are clear contractual obligations. It's no longer a pilot subject to local funding. There would be expectations that would need to be met. There would be monitoring and accountability and tracking of those pieces. And so I think that's why we propose the structure and the change from a local kind of funded initiative that's piloted and varies and only maybe has certain components in certain counties to a more statewide sustainable structure that allows for, yes, an investment in general fund, but ultimately a more kind of improved outcome where we pulled the best practices we can from where we have seen great success in the state.
Okay, and then just a final question before I turn to Dr. Pan or Senator Melendez. So I was in the mid '90s, and I was part of an evaluation looking at this concept in Oregon child welfare system. So we've been doing these pilots forever, right? Where we realize that we can't just treat one part of a person; we have to treat the whole person and the whole system that they live in. So why are we ready now, right? We've been trying these forever, and starts and fits and pilots and pilots and now we're ready, you think?
Well, what I would say is that while we've been doing the pilots for a long time, we've seen a lot of successful pilots as well. And taking that on a statewide basis and ensuring that we are making these services. I think the combination of bringing the medical and the social side and looking at the whole person, the value of that is significant. And I think now the moment is clear. I think I can't even stress the lessons learned that we've had through COVID in regards to, there's been moments where we're saying, if we really just had CalAIM in place, think about the response to the homeless that we could have had across the state of California to move quickly, the housing components in here. We have to start building the infrastructure across the state now. We have to find where there are gaps to start moving the needle, because if we just keep putting it off, I think that we're going to continue to see the number of homeless increase. We're going to continue to see an increase of, whether it's suicide rates or increased mental health issues that are not being addressed. I think we have to invest the funds now to start seeing changes at the delivery system. And it will take time. It's not going to happen overnight. But I think now is really critical, especially what we've learned during the public health emergency, and having these pieces, the connection of health and social really highlighted, and elevating that is critical at this time.
And the plans are ready?
I think that the plans are very excited about, for example, in lieu of services, plans have been pushing for us to implement for years because of the learnings, especially around the aging population and how successful it can be at reducing costs. I think that that's why we are putting incentive dollars in to make sure we provide really tight technical assistance and accountability with the managed care plans. And we will work closely with them to move the needle. But I've yet to hear a plan say that they aren't excited about CalAIM. It's more of why we put phasing in place, just to make sure that they can be as successful as possible in doing this over a period of time instead of everything going on at once.
Thank you. Dr. Pan.
Thank you so very much, and appreciate the presentation. I do have several questions, especially given the scope of the proposal. I would make note that I do remember the initial implementation of some of the whole person care pilots, and while there may have been, there are successes, there are also significant challenges, and we did have people having problems. But I do want to say that overall, I would just express general support for what you're trying to accomplish. But one of the things that I think overall, there's a lot that's being expected of the managed care plans, and so I guess my first statement is that one thing that's going to be essential to making this successful is oversight and accountability for this, and this is before your time, Ms. Cooper, but I've, when I was chair of the Assembly Health Committee, and then later here in the Senate Health Committee, I've always said that we can't contract out responsibility. So the agency needs to be accountable to us, and I never want to hear that, well, the plan did that. It wasn't us, because we're the ones who made the contract, we're the ones who signed the contract, including any consequences that are embedded in the contract for failures that may happen. And so I just want to, first of all, make that clear that just because we have a managed care plan do it, we still are responsible for the outcomes directly. We can't blame the plan. Now, the plan may have had some fault, but again, we're the ones we're the ones who made the contract. So first of all, one question is, part of what we're proposing is to include essentially long-term care and LTSS services into the managed care, essentially carve them in, and the managed care benefit. When we establish our capitation rates for the different plans, long-term care is something that's much more expensive. So is there a separate capitation rate for the people who require long-term care services from the rest of the population? in that plan, or is there some way so that we can tier that out so that we don't have essentially the tail wagging the dog? What I mean by that is that the amount of expenditures for someone who requires long-term care services is much higher than, let's say, a child or a working adult and so forth. And if we only give them one overall capitation rate, we could have a situation where we see basically the plans driven by that one population and the other populations perhaps being even shorted because if in order to make all their books work out. So I just want to be careful that we don't create a capitation system that basically creates dysfunctional incentive. Well, I guess incentive create. That drives decision making that that may not necessarily be beneficial for the entire population, and so recognizing that you have a subsegment that is much more expensive than the other group, that we don't have a situation where it's driven one way. So can you just speak to how we're going to handle the payments if we're carving in long-term care into it? How are we planning to establish our payments to the plans?
Sure. So one thing I would say is we do have plans who have long-term care carved in today in their responsibility. So we do have experience from that perspective. We are proposing a blended rate with long-term care and the SPD population. And if there's questions regarding that, I know Lindy Harrington is on and she can speak to those. The one thing I would say, though, right now, where we don't have the incentive from a healthcare perspective, when long-term care is carved in and we provide them the in lieu of services that allow them to transition someone from a long-term care environment into a home or assisted living with whether it's home modifications or medically tailored meals, it's a lot less costly. When we carve it out and carve someone out of managed care and into service.
Yeah, I'm not talking about carving them out. I'm talking about the population. So what happens is that you have a population of people who either need long-term care services or that they would have a separate capitation rate than, let's say, a child who's some possibility but much less likely to need those services, right? So what happens is we need to recognize we have different risk stratifications within the Medi-Cal population. Right. So if you have a population of people who are at higher risk for needing long-term care services, and you do want them to say, hey, look, you know what? Instead of putting you in a nursing home, we can do medical meals or do home modification. Then that makes sense. The problem is that if we take a group of people who are at much higher risk for fairly expensive services, and we mix them in with other people who don't, then sometimes you can get some. So in other words, essentially some sort of risk-based payment related to the potential risk of need for long-term care. So we don't basically have a plan that goes and sits back and says, well, this is what's driving our expenses, and so we're going to focus on that, and then we're going to subsidize it with people who have less needs. So I just want to be sure. I'm talking about population stratification. I'm not talking about carving out.
Yeah, no, I understand what you're saying, and we do have a separate category of aid for the long-term care. I'm going to ask Lindy if you would like to provide some information to Senator Pan in regards to how we're proposing to build the rate for the long-term care that may give him some understanding of what we're doing there.
Sure. So Senator Pan, just to confirm for you, we do have separate rates that we provide to the managed care plans based on this population. So, for example, there's a separate child or a separate adult rate that is different than our rate that we provide for seniors and persons with disabilities or individuals with long-term care needs. We are proposing to do a blended rate associated with those long-term care needs and the individuals with seniors and persons with disabilities in order to create some of those shared savings structures where we can do some incentives to ensure that we are getting the right care to our beneficiaries.
Okay. All right, I appreciate it.
And ensure that they are properly funded. Okay,
well, I appreciate it. Perhaps you can send me some details on that. We don't need to go through all the details right now here in the hearing. The other question here is that I understand part of the proposal is that you will require all Medi-Cal managed care plans to be accredited by NCQA by 2026. Now, maybe you can comment on why 2026, why not earlier? But then also it states that DHCS will no longer conduct independent oversight of those requirements. So I guess what I'd like to understand is that, so what kind of standards are, so if you're going to defer to NCQA for those, and then you're going to do oversight over other requirements, can you talk about the oversight process for the plans, especially as we're giving them more responsibilities? And so if you're going to say, okay, well, good, we're going to get them all accredited by NCQA, what happens if a plan falls short? Do we leave the penalty to NCQA, or I guess if they lost accreditation, I guess you could just not use that plan, although I'm not sure how that works, if it's a COES or it's a, if it's one of the two plans, do you just simply find a second plan? So can you just talk about how this NCQA accreditation is going to work, particularly when it comes to if either they fail accreditation or they don't meet, and they may not have necessarily lost their accreditation, but they have some failures in meeting that. Do we just leave it to NCQA, or do we actually have some consequences for plans that do not meet the NCQA requirements, but not to the degree where NCQA itself may remove their accreditation?
Sure. So we are proposing to have the accreditation by 2026. The reason why we needed that long is we did work with the NCQA and plans who have already become accredited in regards to the timeline that it takes from requirement. It takes about 3 years to get full accreditation. And so that's the time period in which everyone has to be fully accredited by, just to clarify that point. And so that's why it's the later years there. For the point around what we call deeming in regards to using NCQA accreditation, about 16, I believe, of our managed care plans are currently NCQA accredited, so it would just be the gap there. But we currently don't do any deeming today, other than credentialing, where we do deem to NCQA for credentialing in California today. We would like to explore some NCQA deeming, and by that I mean where we would have NCQA be the main source of the review for those various administrative functions and requirements. However, we do propose to have full transparency and stakeholder engagement around what the department would deem to NCQA versus what we would continue to do through our ongoing oversight and monitoring. So we do want to have the legislature be able to weigh in on that, for example, in the future, depending on what we recommend there. However, it would not take away any of the state's ability to still hold managed care plans accountable. If for some reason a managed care plan lost accreditation, first, before you just lose it, you go into their stages of that. The department would intervene quickly and early in regards to any of those items and probably take over site in regards to all components that are within the deeming area. We also would put our managed care plans immediately on corrective action plan and utilize sanctions if necessary, if someone were to be in jeopardy of such a loss of accreditation. So while we do want to increase the standardization across all of our managed care plans with NCQA accreditation, similar to Cover California and others who have NCQA accreditation requirements, it would not prohibit the department from all oversight and requirements, as well as full transparency in regards to any areas that we do deem to NCQA versus putting our resources that we're otherwise looking at certain administrative functions to, really focusing on, for example, increasing improvements in quality, delivery system transformation, and equity.
Okay,
so hopefully that answers your question.
Okay, so certainly, it's not the issue of when you said that it doesn't prohibit the agency from acting. I just want to be sure that that the agency in deeming, and deeming is fine when you have an organization like NCQA, but that the policy doesn't become like, oh, well, since we've decided to deem that we're not going to do anything about it, right? So yes, there's nothing that's in the proposal that would prohibit DHCS from acting. I just want to know if DHCS will act and not just simply say, well, we've now decided to deem to NCQA, so we're not responsible anymore. So I just want to be sure that doesn't become part of the culture, in terms of the message we're sending. And I appreciate that there be public transparency around the deeming process. Regional managed care rate setting, certainly understand part of what you're trying to do that. Can you describe, I understand we don't know what the regions are. Are you going to use the Cover California regions? What kind of regions are you using to establish a regional managed care rate setting?
Sure, I'm going to let Lindy Harrington answer that question.
Okay, thank you.
Yes, Senator Pan. So we are still working through what those regions will look like, and what we will match those up with. We've been doing some research to try to determine, based on the Medi-Cal information that we have today, to ensure that those regions have similar cost profiles, similar experience. And so we're continuing to do work, and we will also continue to work with our managed care plan partners as we establish those, to ensure that they are in alignment and are appropriate.
Okay, yeah, so certainly that's going to be really important. For example, in the Medicare program, for example, Sacramento is considered a regional area as a rural area. We're obviously not very rural, and so our cost structure and payments and Medicare are distorted because of that. And part of it's because it got established back, decades ago. So when it comes to regional managed care rate setting, I think we certainly want to know what those regions are going to be. Also want to know how those regions might evolve over time, reflecting potentially population shifts and other things that will, of course, happen over time, demographic shifts and so forth. So I think we need to have much more detail on that. And then now we talked about the enhanced care management. And you talked about you have a description of the target populations. So can you just speak to what percentage of our 13 million million people who are on Medi-Cal managed care plans would actually qualify for enhanced care management? How many of them?
So we don't have an exact percent. What we do know is that.
Well, okay, what about a rough percent? I got no exact. Okay, so what? We're talking 10, 20, 30, let's close this 10%.
No, it should be the enhanced care management is for your top highest, whether it's utilizers or most complex individuals that are facing kind of both the medical and social drivers of health. So it's not necessarily as easy to put a percent on, which is why we typically don't give a percent.
Okay.
I also think that it's going to vary based on the different target populations. And one thing I would just mention is just those that may be eligible, the number that engage is a very different number because of the complexities. And so that's why it's hard for the department to put a specific number on.
Well, I get you can't give a specific number, but I think scale is important, right? So, and for example, one of the target populations are people who are at risk of being homeless or homeless, right? And by the way, they're hard to reach. So when we're doing contracts with managed care plans, what we don't want to do is have them contract, right, for the population and then not do sufficient outreach and then basically, so, we got, so anyway, I think having at least a range is important. So, and so I'm just thinking scale. So are we talking about the top 1%, the top 3%, the top 5%, top 10%? There's a difference between saying we're only going to do the top 2% or the top 10% or the top 20%, right? So, at least in trying to figure out how, what exactly we're trying to budget for. I mean, we have 7 different mandatory target populations. We should at least have some expectation about roughly how many people these all add up and how many people are in each category. So individuals experiencing chronic homelessness are at risk of being homeless. How many people are we talking about that we're going to expect the managed care plans to reach? Is it going to be the 130,000 we're expecting? So that I'm trying to remember what the.
And I see LAO has their hand up as well.
Yeah, maybe LAO can help out with that too, but yeah.
Yes, Senator Pan, at least for budgeting assumptions, I assume this would be the percentage of Medi-Cal managed care beneficiaries that would be served through ECM. Our understanding is that the assumption is 1%.
Yeah, I was just going to say, from a pure rate perspective, we have historically been using 1%. That was
Okay.
driven by our experience in both health homes and whole person care. And we will fine tune that, but that doesn't necessarily mean that's the number that would be eligible. That's based off of those that engage or have historically based on our experience. So that's why, if it's what's being built into the rate, it is currently, we're projecting around about a 1% of Medi-Cal beneficiaries for the enhanced care management.
Okay, so that's very helpful to know. I think it's important to know, because you talked about engagement, but engagement, it also, sometimes engagement's dependent on outreach, right? So, engagement's a two-way street. And so as we're building these things out, and again, I appreciate, the picture you painted, and I think we'd all love to see the thing, but, the person who frequently goes to the ER, if the plan isn't engaging, right, because they're like, oh, we already have 1%, and that's what we got paid for, then we're not really meeting the promise that we're these painting. So I think we need to set appropriate expectations for how many, and so 1% is, and again, I know that we're talking about focusing on the most highest risk people, but there's a lot of things here we're talking about that we're going to try to provide that people are like, hey, yeah, that'd be great. But if it's only for 1%, then people need to know that, okay, if you're the 2%, which will still have a lot of needs, not as much as the 1%, but still pretty high, you're not going to be eligible. You may not be, or what's the percentage that are eligible and the percentage we're spreading, funding for? So we got to know that. Is that 1%, half of all the people who might be eligible? Is that a third? Is that 80%? So that we know where we're heading toward, and how well we're resourcing. In lieu services, again, appreciate the variety of different things here, but it also says allow plans to voluntarily include one or more in lieu services. So, so does that mean the plan gets to decide whether they want to do? Well, let's see, how many do we have here? Well, we have several potential ones, but so what kind of so is it something the plan decides, or is that something their DHCS negotiates with the plan, or what kind of oversight is there about which in lieu services they provide? Is there any expectation, for example, if the plan serves a population with that has a high need for several of these, like homelessness, housing deposits, housing tenancy, that they will include that, or is it up to them to decide which ones they want to include and which ones they don't? And then how would that affect people's access to these services?
So the federal regulations that we are using to implement the in lieu of services does require that it is voluntary for the managed care plan to provide them or not. We have a model of care and transition template that's currently out for public comment right now in regards to the filing timelines that managed care plans would make with the department for which in lieu of services that they are continuing. We have, for example, done a crosswalk of all of the existing in lieu of services being provided within both health homes and whole person care for our managed care plans so that they can continue to provide those services. One of the most challenging things with getting in lieu of services up is identifying the correct providers, because there are clear subject matter experts who should be providing those certain types of services. And so we will be encouraging all of our managed care plans to continue the services provided in whole person care and then expand to the other in lieu of services. There are 14 of them, so we don't imagine all managed care plans will take up all 14 at the same time. But we do hope that they would be phasing those in over time. We do allow for them to add in lieu of services every 6 months. And so we'll know by the summer which in lieu of services managed care plans anticipate at least providing in the next year or two, or proposing to be able to assess gaps and encourage them and connect them with providers who would be able to provide those services in their community. The only other thing I would add is that with the upcoming procurement for our Medi-Cal managed care plans, it will be very clear that any managed care plan wanting to enter into the California market would be expected to come in with a full proposal in regards to how they are going to provide in lieu of services in California and demonstrate that to us.
So when you So when you say that in the procurement, is their plan supposed to talk about all, as you said, how many were there, 14? I didn't count them all.
Yeah, there's 14.
Okay, so are they supposed to come up with a plan to talk about how they might incorporate one of them, all 14, something in between?
What I think we would say is, at a minimum, mirroring their local initiative. For example, if they're a commercial plan and they have a local initiative, they should at a minimum be able to provide what that local initiative is providing in lieu of services to have coverage across the entire county, and tell us how and what in lieu of services they would be offering of the 14, to ensure that anyone coming into our market is very committed to bringing up, even if it's over time, a phase-in of these in lieu of services. That will be a very strong requirement for us through the procurement.
And then, all right, so just to clarify, so we have some counties that are COs, they're one plan, so they'll have whatever in lieu services they choose. Then you have 2 plan counties, you have GMC counties, the rural counties, I think they'll have usually one or at least a couple plans. So in counties with multiple plans, are we expecting the plans within the same county to at least offer the same set of in lieu services, or are they going to have different sets of in lieu services?
So we are within 2 plan, for example, we are going to encourage plans. However, under federal regulations, we cannot mandate it, just to be clear. And so we will be encouraging plans to work together to provide the same lieu of services for individuals. Through the procurement process, we will also be reducing the number of plans in GMC counties, and that will be rolled out through the procurement process. And so we are going to do everything we can to work with the plans, commercial and local initiatives, to align and provide the same in lieu of services in a county. Typically, the big thing and lift for getting in lieu of services up and running is identifying providers who have the ability to provide those in lieu of services. And so brokering those conversations of providers across both of the plans to invest in those services will be work that the department will have to engage in.
Okay, I appreciate that the biggest barrier is the providers, but I'm also just concerned that counties with multiple plans, if people have different sets of in lieu services, then you're going to have. So I don't know if that's going to affect your capitation rates or something, because obviously that you may attract different types of populations. Then the other issue is that the Medi-Cal population, sometimes people don't always decide which plan. Well, let's say technically they decide which plan, but oftentimes they may not make a decision and get placed in the plan, and then that you may find people in. Well, you have a combination of either people find themselves, automatically placed in the wrong plan, or you could also have distortions in terms of what populations. And what we don't want to do is have managed care plans actuarially go, well, I don't want to provide that in lieu service because I don't want to be the one to attract all the homeless people, right? So we'll avoid those services. And hopefully the other plan will do it, and then no plan will do those because neither one wants that population because it's much harder. And so I don't know. For example, I understand you said federal regulation requires that the in lieu services that they do are voluntary. Do you see any adjustments to their payment rates for plans who choose to decide different in lieu services? We gather more data on how populations will benefit from receiving certain in lieu services that might actually cause differences in case mix.
Yes, we would eventually, as they provide the in lieu of services, that would be built into their rate. So if they are providing them at a higher rate or more in lieu of services, that eventually gets built into the rate. And as scored in the budget right now, because of the in lieu of services provided through whole person care and health homes, as those transition in those counties, we account for those plans that elect to get those in lieu of services to receive those funds through the budget as well. So they would be funded, which would be their, which is important for them to have that funding right now so that we don't have the drop off of those in lieu of services and they could maintain those services within the county. So the CalAIM proposal accounts for both of those.
Okay. And just I do want to point out it in terms of the expenditure authority, the amount for in lieu services under local assistance resource request was here said essentially 48 million. Is that reflect, what was that reflect? So
that is 6 months worth of in lieu of services, because we're only scoring 6
Okay.
months, and there's a cash lag. But I believe it gets close to, and of course I don't have my annual numbers in front of me, but it's like about 115 or so, if I'm going off of memory, $1 million for in lieu of services. And that's based off of our experience with the services being provided through Health Homes and Whole
Okay.
Person Care today based on utilization today.
Okay. And then finally, I just want to touch on, I know that under staffing and resources request, actually I note that the Medicaid Managed Information System Division only had one additional information technology specialist. So I guess, and I know we're going to delve a little more into the IT stuff, and there's other BCPs for IT, but I don't, in terms of CalAIM, what, can you just more speak generally in terms of IT, I think oversight and data collection is going to be really important, right? We're doing this huge transformation. We need to know where we're going, how's it going, and so forth. What do you see as the IT demands for moving on to CalAIM in terms of being able to do the kind of assessments and oversight and accountability? And then the other part is that I know you're adding some additional personnel in managed care quality and monitoring division. But again, I'd say with this broader role for managed care, and I think that's really going to be the nub of the question, the nub of the issue is that I don't think the concern is with the goals. I think the question is that what we don't want to do is contract out the responsibility and accountability. So therefore, is that enough staff to be sure there's sufficient accountability for the managed care plans? And what happens when a managed care plan doesn't deliver on the things that we count on? So, and what the consequences for this? How long are they on a corrective action plan before something happens? What options does the HCS actually have, given the fact that many counties, there aren't many plans? So, I mean, it's not as simple as simply turning off the plan. So can you speak to the staffing? So I guess I'm actually bringing up the issue, do you have enough staff to be sure you do enough oversight? So I know you're asking for a lot more staff, but I'm just wondering, do you have enough to be able to do the level of oversight that we're going to expect for such a large transformation?
Sure. So on the EITS, or the Enterprise Technology Services, we do have a request for some staff there. We did separate out our systems ask, which, as you mentioned, will be coming later with a modernization of our systems. And so that's why you're seeing it maybe not as reflected as strongly in the actual CalAIM BCP.
Okay.
We went back and forth whether we should put them in the respective pieces, and landed where we separated the two asks. But you do see some in the CalAIM, but not as much as what you're seeing in the request on the enterprise side. On the MCQMD, what I would say is, we don't currently, other than the minor credentialing piece, we don't deem any of those oversight functions today. So we have existing staff doing that. The request here is the additional staff for the additional oversight of enhanced care management in lieu of services, the additional lives coming into managed care, and to tighten up and shore up some of our services in regards to that oversight and monitoring. And that spans over both the managed care quality and monitoring division, as well as the managed care operations division. So just pointing out that they both are asking for, pretty significant resources to add to the additional oversight pieces. And then would just say we have some other staff from our existing kind of within the limited term and the ongoing permanent requests. Some of those permanent positions in the other BCPs are from our oversight and increased monitoring within the final rule, the managed care final rule that came down, in converting those to permanent requests. That also helps from an oversight and monitoring, and that is just in a separate BCP where we are asking for those positions.
Okay.
If that helps
Okay, that's
how they're
helpful. And you don't have to answer this right now. Be interested in having some more information about how oversight is going to be handled for CalAIM, and how we got some things that we're planning to do differently or the same in terms of oversight. And then on the IT side, given the Now, I want to just be fair. We've actually successful IT projects don't make the news. And so we do have successful IT projects in the state. Sometimes it seems like because the ones that we have problems with make the news. So I don't want anyone to think that we don't have successful IT projects. But we also have had IT problems. We've had legacy systems issues, et cetera. So also would like to, perhaps you can report back on for CalAIM, are we looking at new IT systems or having to significantly upgrade existing IT systems in order to be sure we can collect the kind of data we need, because we're going to collect a much broader set of data, I assume, if we're doing the in-lieu services and the whole person, et cetera, and that we're going to have a system that's robust enough that we can get the answers to the questions we'll have later in terms of implementation, how successful implementation is, and outcomes. So if we can get a report back from DHCS and or the appropriate agencies on that prior to in the next few months, that would be very helpful prior to May revise.
We'd be happy to.
Okay, thank you.
Thank you very much, Dr. Pan. And can you just, and I think what you're hearing from all of us is the optimism about the programs, but also the concern about oversight and accountability. As somebody new to the budget committee, but with a strong interest in